Hi friends, in this video I will talk about approach to a case of arthritis. First is the disclaimer. Friends, arthritis means swelling of one or more joints, usually with the pain, warmth, tenderness and limited movements. And it differs from arthralgia. Arthralgia means joint pain without any swelling or abnormal finding on examination. Arthritis can occur in many rheumatic diseases, and sometimes it may even be the first sign of other illnesses like hormonal disorders or cancer. While evaluating arthritis, we should check whether the pain is articular. Articular means that is whether the pain originates from the joint, or non-articular pain means when the pain originates from the muscles, tendons or bursas. We have to look for type of inflammation, whether the pain is of inflammatory origin or non-inflammatory origin. Inflammatory means patient have systemic symptoms, morning stiffness of more than half an hour to 1 hour, when there is swelling, warmth, redness. And inflammatory arthritis is further categorized as monoarthritis when it involves only one joint, as seen in gout, septic arthritis, TB arthritis. Oligoarthritis is when it involves 2 to 4 joints, as seen in gout, spondyloarthritis, psoriatic arthritis. Polyarthritis is a condition when it involves more than 5 joints, as seen in rheumatoid arthritis and SLE and psoriatic arthritis. Non-inflammatory arthritis does not have systemic features, and it includes examples of osteoarthritis and hypothyroidism. We have to look for number and pattern of the joint involvement, whether there is involvement of one joint, many joints, what sort of joints are affected on one side or both sides. So whenever we are assessing the patient of arthritis, we have to take the detailed medical history, the position or the which joint is involved, what is the character of the pain, whether it is associated with stiffness, swelling, redness, whether there is limited mobility or function of the joint, what is the duration of the arthritis or the pain, what are the patterns of the symptoms. Family history of arthritis or autoimmune diseases, previous joint injuries or surgery, current medical medications and supplements, what are the lifestyle habits, for example, the exercise, diet, smoking pattern. After detailed medical history, we have to do the physical examination. We have to inspect the affected joint for swelling or redness, warmth or tenderness, deformities or contractures. We have to assess the joint mobility and function for the range of motion, strength, stability, gait and balance. We have to check for extra articular features like skin rashes, any involvement of the eye, gut, etc. We have to identify the type of arthritis based on the history and physical examination. We have to consider the possibility of osteoarthritis when it involves wear and tear, rheumatoid arthritis in autoimmune diseases, psoriatic arthritis when it is associated with psoriasis, and other type of arthritis like gout, lupus, ankylosing spondylitis. This initial assessments helps a physician to make a preliminary diagnosis, identify the potential red flags. Red flags are signs of infection or malignancy, and determine the need for further diagnosing or diagnostic testing and treatment plan. These are the various pattern recognition in arthritis based on the mode of onset. Acute onset of arthritis is seen in septic arthritis, reactive arthritis, viral arthritis due to gout or trauma. Insidious onset of arthritis is seen in rheumatoid arthritis, spondyloarthritis, and osteoarthritis. If the duration of the arthritis is less than 6 weeks, we call it as acute. It is seen in viral arthritis, When the duration is more than 6 weeks, we call it as a rheumatoid arthritis. So, depending upon the number of joint affected, monoarthritis involves single joint. It is seen in septic arthritis, tubercular arthritis, and gout. Oligoarthritis is seen in gout, juvenile, idiopathic arthritis, and spondyloarthritis. Polyarthritis is seen in rheumatoid arthritis and SLE. Symmetrical distribution of arthritis is seen in rheumatoid, and asymmetrical arthritis is seen in the gout. Lower limbs are usually involved in spondyloarthritis, whereas the upper limbs are involved in rheumatoid arthritis. Small joints are also involved in rheumatoid arthritis, and large joints are involved in spondyloarthritis. Distal interphalangeal joints are involved in osteoarthritis. Patient can have extra-articular feature like fever in adult onset Still's disease, mucocutaneous lesion in SLE, eye involvement in spondyloarthritis, and nodules in tophaceous gout. So, intermittent arthritis is a palindromic rheumatism. Migratory arthritis is a feature of rheumatic fever. Additive arthritis is seen in rheumatoid arthritis. These are the reference from Sir Handa Clinical Rheumatology. So, in the next step, when we have recognized the pattern of arthritis, involvement of the joints with clear medical history and examination, we have to do the diagnostic test. The blood tests which are done are rheumatoid factor, anti-CCP, ANA, ESR, CRP, CBC, liver and kidney functions. X-ray is done to rule out any bone or joint damage. Ultrasound helps in finding out the synovitis and inflammation. MRI helps us in diagnosing the joint and soft tissue inflammation. CT findings are suggestive of bone and joint damage. Joint fluid aspiration, that is synovial fluid aspiration, helps in detecting the infection, inflammation, and crystals. Other tests like urine helps in finding out the kidney disease, stool helps in finding out the GI bleed, and bone density helps in osteoporosis. The treatment plan is usually individualized. It varies from individual to individual. The non-drug or non-pharmacological measures are patient education. It helps, we have to make the patient understand his condition. The treatment options are to be given to the patient, and even he is also told about the self-management of the mild symptoms. The lifestyle changes include exercise, weight control, stress and smoking cessation. The various use of various assistive devices like cane, walkers, splints, orthotics, they are to be encouraged to for the especially for the elderly patients. Physiotherapy is very useful in these cases, and it helps in flexibility, strengthening of the muscles, improving the range of movements. Then coming up to the medications or the pharmacotherapy, the patients, they get relief with analgesics, corticosteroids, prednisolone, disease modifying anti-rheumatic drugs like methotrexate, hydroxychloroquine, biologicals like tumor necrosis factor alpha, interleukin 17 blockers, targeted synthetic DMARDs, DMOIDs for osteoarthritis are very useful depending upon the diagnosis or the cause of arthritis. Surgery like joint replacement for hip, knee, shoulder may be required in some cases, and in some cases the patient may be subjected to joint fusion, osteotomy, or tendon or soft tissue repair. After the treatment, the patient has to visit the treating doctor every 3 to 6 months for regular review, assessment of the pain, for the assessment of the pain, function, and the quality of life is assessed in all these reviews. The doctor or the treating doctor assesses the disease activity score like DAS 28, CDAI. It helps To differentiate the present condition from the flares or the progression of the disease, in the regular reviews, side effects are also monitored. The patient is subjected to liver, kidney, and various other tests to rule out any multi-organ failure or the risk of infection or the malignancy. Patients are also advised for lifestyle support. They are encouraged to do the exercise, maintain their weight, stress management, and smoking cessation also helps a lot. Patients are imparted continuous education and self management support. As a caregiver, you see selfless acts every day. With this, I conclude my today's topic. Thank you. Keep learning.